Thanks, everyone, for joining this webinar. We couldn't be more excited to welcome two very special guests, Tricia Neuman and Mark Miller, two nationally recognized healthcare policy luminaries who will be sharing the insights on drug pricing reform and strategic implications for employers and health plans. We've had close to 1,000 people sign up, so welcome to everyone who's joining us today. I see got about 250 in the room and more coming. And I wanted to just let you know that I'm Cybele Bjorklund. I am our Senior Vice President of Policy and Government Strategy at Virta. I'll be our moderator and host today. Before I introduce our key speakers, I wanted to share a few housekeeping notes. This webinar will be recorded. We'll be sending the recording to all guests. We're trying to reserve 15 minutes at the end for Q&A. So to ask questions, please type your questions in the question panel on your screen and we'll pass along the upvoted questions to our panelists. And I want to take a moment to welcome and thank our panelists, two very special guests. We have with us today Dr. Tricia Neuman. She's the Senior Vice President at the Kaiser Family Foundation and the Executive Director of the Foundation's Program on Medicare Policy. Prior to her service at the Kaiser Foundation, she served in the professional staff of the House Ways and Means Subcommittee on Health and on the staff of the U.S. Senate Special Committee on Aging. Tricia's work has been instrumental in shaping Medicare policy through the years, and as such, she was recently nominated by President Biden to serve as a public trustee of the Medicare and Social Security programs. Thank you for joining us today, Tricia. We also have with us today Dr. Mark Miller. He's the Executive Vice President of Healthcare at Arnold Ventures and a nationally recognized health policy expert. Prior to coming to Arnold Ventures, Mark was the longtime Executive Director at MedPAC and held senior leadership roles at OMB, CMS, and the Congressional Budget Office. Through these roles, Mark has been directly involved in the development of virtually every major piece of health financing legislation in the last 20 plus years, including the Balanced Budget Act, the Medicare Modernization Act, which created Part D, the Affordable Care Act, and many, many others. Welcome, Mark. Both Tricia and Mark serve as trusted subject matter experts in the policymaking process. I see their fingerprints all over various pieces of the Build Back Better Act, even if they can neither confirm nor deny any input. And we couldn't be more grateful and honored to have them with us today. I'm going to set the scene by reviewing just a couple of points, and then we'll run through some issues again, followed by our Q&A at the end. Next slide, please. So we are here today because there continues to be a concern among payers, patients, and even providers that drug pricing practices and spending increases are unsustainable. While more than half of the drug price increases in Part D were above inflation in 2018 to 19, that's really the tail wagging the dog. This problem has been brewing for the last 15 years, and yet policy progress has been elusive. Next slide, please. For Virta patients, many of whom, and our customers, the health plan and employer clients who come to us to reverse their diabetes by improving their A1C in order to reduce or eliminate the need for insulin, this slide is particularly important. 7 of the top 22 price increases were for diabetes-specific drugs, and 6 of those 7 had increases more than double inflation. Next slide. So my friends in pharma, and I do have friends in pharma, would say that list prices don't matter. And for reasons we'll discuss today, they're not totally wrong, but they're also not totally right. And I think it's really important for us to dive into these pieces of the puzzle. So we can take the slides off and open up. So before we get too far on that last point, let's stipulate that the US system for purchasing pharmaceuticals and biologics is fractured, opaque, and often plainly irrational. Furthermore, the supply chain between R&D to patient includes an array of players, many with competing incentives, which further complicates reform efforts. Moreover, it's hard to talk about the affordability umbrella because it's actually used to describe a number of different challenges, because the complexity of the system means there's no one-size-fits-all solution. And proposals to address high prices for innovative or even only modestly innovative, best or first-in-class sole sort treatments are totally different than what's needed to tackle the times where we see obscene price gouging for some products that are long off patent, but nobody else is producing. So if you're not tackling the entire system, because spoiler alert, that's not happening, how do we prioritize on the continuum of cost versus utilization? Are we going to focus on high cost, low utilization drugs, low cost, high utilization, or anywhere on that sliding scale in between? Totally easy topic. So we'll bite off a few pieces today for what I hope will be an interesting and informative conversation, starting with lessons learned, reviewing what's on the table right now, and other related issues, and then Q&A. So I'm a firm believer in the past informing the future, and I think we should start there. And I'll toss it first to Tricia and say, why have past efforts failed? And what do you think we've learned from those exercises?
Thank you, Cybele. Thank you for inviting me today to join you. I guess the concept of success or failure is in the eye of the beholder. Some people might say that the past several years have been very successful because there hasn't been any legislation or regulation that has moved through that has seriously affected high drug prices. But whatever perspective you take, I think it is fairly safe to say that there has been very few efforts have made it across the finish line when it comes to prescription drug pricing. And I'd like to point out that it has been sort of an equal opportunity success or failure, because this is something that has been true of the Obama administration. It has also been true of the Trump administration. And we'll wait and see what's going on in the course of the Biden administration. But President Obama tried to do a pretty ambitious Part B, that's the physician-administered drug pricing proposal, a demonstration that was withdrawn before it was implemented, and it was highly controversial and opposed at the time. President Trump actually tried a number of different options. You may remember the most favored nation demonstration, which was designed to peg prices to European prices because of his concern that the US was being price gouged. That didn't make it through. That was opposed. The Trump administration also tried to get price disclosure in ads to try to sort of bring out sticker shock for people. That too was blocked in the courts. And there was a proposal to get at the so-called middlemen, that's pharmacy benefit managers, that didn't make it across the finish line. And that had something to do with the fact that the proposal would have significantly increased Medicare spending and premiums. There have been many efforts and they haven't really succeeded. I think it's hard to overstate the effectiveness and the success of the pharmaceutical industry that is very concerned about any effort to establish prices or limits on prices. But I also think that we shouldn't forget, in terms of lessons learned, that this is an issue that taps very deeply into the concerns of employers, employees, the 65 million people on Medicare, public and private payers. So this is a real issue. When we do polling on where is the public on this, 29% say they haven't taken a prescription because of costs. 26% say they can't afford their medications. More to the point, 83% say that the cost of drugs is unaffordable to them. So while efforts to do something about drug costs and affordability have not quite succeeded so far, that doesn't mean that there's not strong interest among multiple payers and parties, including, most importantly, the public and people who are sick who can't afford their medications, to get something done.
Yeah, thank you. I think that's what's really important is, this is an issue that cuts, as you said, across party, both from a political standpoint, but also voters and everyday Americans who are polled and concerned about what's happening here. Mark, when you look at some of the work that you all have supported and evaluated, when you think about where there has been success, what have you seen maybe in the States or even elsewhere that would be instructive for what we could look at federally, or even if it's not instructive federally, why it's been a successful effort in the States and is worth just thinking about here?
Yeah, I do agree with a lot of what Tricia said. I may return to it briefly, but just to answer your question directly, it has been very hard at the federal level to get traction for all the reasons that Tricia said. Many states have gone on their own, and many states have been compelled to do something. Say, for example, with the arrival of the Hep C drug, with its original pricing, was a real shock to the states, Medicaid populations, prison populations, that type of thing. And given the price at that point, I mean, the way they were proceeding was basically restricting access. And so that was something of a compelling event. And that drove things like, and I know you're both aware of this, and probably all 250 people on the show as well, but then you started to get things like the Netflix model approach that the state of Louisiana worked through, and some other states were looking at it. And we definitely tried to help out there. You see things in New York State on their Medicaid program anyway, where they have kind of a guiding target for spending. And when a new drug shows up, if they exceed that spending, then they go through a process of why is this drug so high? Is there an additional discount? They've pulled on research that ICER has done and things like that in order to try and work through those kinds of issues. You've also seen some development of prescription price boards. And now they have different levels of teeth, whether it's just you will produce information so we can see, this is the state speaking, we can see the price changes, or you have to come in and justify them, and there's a public process to that, or moving to, no, there are specific limitations that we want to consider there. Of course, which markets they're focused on, whether it's commercial or the state employee, varies, from state to state. And then you also, the last thing on the state front anyway that I'll mention, there is one other thing I want to mention, is things like bulk purchasing, where states are trying to get together and so related to their Medicaid programs and that type of thing. Then you have things like Civica, and you had the slide up briefly, like Mark Cuban, where people are just kind of entering the market and saying, I'm going to do this. And Civica's original idea was, if there's a generic drug and the license, the approvals for it all exist, it's like, purchase or rent the license, purchase or rent the manufacturing, and enter the market yourself. And then, give it to your hospitals in your network. So there's been ideas like that people are just saying, if there's not going to be a change, then I'm going to enter. I do want to just say a couple things. Tricia said all the good stuff. And so I just want to say, first of all, associate myself with those comments. And there's been the industry has been very effective at stopping, and that's their role, and that's what they're expected to do, but have been very effective at turning back change. I will say that the notion that you've had pieces of legislation, and in some instances significant legislation, pass the House and back in 2019 come out of the Senate, suggests to me that there is some ability to make progress. And Tricia said this, but I just want to reinforce it. I think the key thing is that, the only thing that beats money is votes. And if you have enough people who care about this, and the polling on this, both Republican and Democrat, was very high. And Tricia was dead right in her point that this stuff started to punch through at what's the expression, the kitchen table, or whatever that is. And it wasn't just drugs. There was surprise billing and emergency room bills and hospitals suing people, and people are just becoming, I think, much more aware of the affordability problem, and everybody is very close to drugs. And so I think that has helped move things along, even though the progress is stalled clearly at the moment. I'm sorry, that was probably long-winded, but I'll stop here.
Not long-winded. It's always good to hear. And actually on the Civica front, one thing we didn't even put up there that sort of piqued our interest in recently was Gavin Newsom tweeted, they're going to start making insulin. Now, I don't know how much, we're still trying to figure out how serious that is, but I know it's been under discussion there for a while. And I think you're right. It get to the point that people are saying, we're just going to do it on our own, which has historically been, couldn't be even contemplated in the past. So the frustration is boiling up. So let's quickly do a little high-level overview of what's in BBB, just so we know what's on the table right now. And Tricia, I don't know if you can run through the key Medicare provisions, and then I think we'd have Mark, you run through PBM Transparency because it affects all the markets, and that to me, for many of our employer and health plan clients, will be particularly interesting and valuable to discuss.
Sure. All right. Well, why don't I start with the probably the most visible proposal that's in the legislation, and that is the proposal to allow the government to negotiate prescription drugs. This passed in earlier versions of the House bill. This is an idea that candidates have campaigned on year after year. They like the idea. This is from both parties. They're very enthusiastic about giving the government authority to negotiate prices. It kind of resonates with the public. It was in earlier versions of the House bill. It's in the current version of the Build Back Better legislation. I need to say that the proposal that's now on the table is far scaled back from what it was. Far fewer drugs would be on the table when it's fully implemented, and that's not until 2028. That would be 20 drugs that year, drawing from Medicare Parts B and D. So that's far fewer than the 250 drugs that were included originally. It's also important to note that it would include all insulin products. So that would be in addition to those 20 drugs, and I'm sure of interest to this audience. There are also exclusions. There's periods of exclusion so that new drugs that come to market have many years to be out there without negotiated prices, without the government coming in and setting prices. So that was a concession that was made in order to find a compromise. So the ultimate version of this one proposal is very much scaled back from what it used to be. And I think you can see that if you look at the CBO cost estimates for this proposal in particular. The earlier versions of the House bill would have saved more than $500 billion on the prescription drug savings proposals. Now we're in the order of less than $100 billion. So it's very much greatly scaled back. And also I need to point out that the most recent version, not the most recent, the version before that would have applied government negotiated prices to private insurance. That is no longer in this proposal. And so that too was a significant concession. So yes, government can negotiate prices, but that's applied to Medicare Parts B and Part D. And that is one feature that's in the Build Back Better legislation. A second major feature is the inflation rebate. You saw from Cybele earlier that there were drug prices increasing faster than inflation. This proposal says, well, yep, if you do that, you will pay a rebate back to the government for the amounts that exceed inflation if your prices rise faster than that. This applies to both Medicare and private plans. So this is one of two areas where the legislation extends beyond Medicare in terms of savings. And this would have a net budget effect of $84 billion. So this is not insignificant. And the idea behind this one was bipartisan in the sense that this came from the Grassley-Wyden compromise that was in the Senate finance package a couple of years ago. The third piece is the insulin cap, which would cap the what people pay for insulin at $35 per month. This applies to both Medicare and to private insurance. We know from our work in Medicare that this will be helpful to people. There is a model that's being tested now in Medicare that would provide caps on the cost of insulin, but not everybody takes the insulins that are subject to the cap. Many people are still paying for insulin on tier 3, which is 40 some odd dollars per month. And for anybody who exceeds the catastrophic threshold, they could pay at least $100 a month for their insulin. So for Medicare, it would go well beyond the model that's being tested. And it also applies to private insurance, to employer plans. So this is really a big deal for people who do take insulin. And I know there's some effort to get people off of insulin permanently, but for those who are reliant, this would be quite helpful. And the fourth provision that I'll highlight is a cap on out-of-pocket spending. This applies to Medicare in particular, because in Medicare, there's actually no absolute hard cap on out-of-pocket spending. There's a threshold above which people in Medicare end up paying a fair amount for the cost of prescription drugs. This would establish a hard cap. It would also shift around some of the financing. This would be hugely helpful to people who have significant expenses, and not just for one particular drug. I mean, I think we all may know somebody who takes very expensive drugs. I've got a family friend who's taking a drug that costs her $12,000 a year because she zoomed right through the catastrophic threshold. So for really sick people who take one drug or multiple drugs because they have comorbidities, this is a huge help. And that is in the package. So I think I'll leave it at that. There is a lot more, but those are kind of the four anchors, I would say.
Yeah, I think that's really useful. And interesting, again, to highlight for our folks that insulin is in that narrower package of drugs that would be negotiated. I think it was really important to emphasize how much smaller the package has gone. It'd still be an enormous step forward, probably, and to allow the government to negotiate and set up some parameters. But this is a much smaller step than it has been in the past. I think.
Right. I mean, I think some people might see this as the glass is half empty. Other people might see it as the glass is half full. But it would be a new step in getting something done about drug pricing. It would also give the secretary time to put the infrastructure in place in order to get this process going and to get the staff on board to do it right. The other point I did want to say is we've done some polling around the government negotiation provisions in particular, because there's been a lot of ads out there saying this will affect R&D and this will affect access. So when we ask these questions, and I would say before we ask the questions, we've known from prior polling that this has broad support from people across party lines. Big majorities of Democrats, Republicans, and independents have supported this policy. When we push them a little bit and use the major arguments on both sides, we found that still a large majority of Democrats, Republicans, and independents support this policy. And Mark was talking about the sort of kitchen table, I want government to do something about my drug costs, and that seems to be manifest here.
Super interesting thing, I think, is I think we've seen basically since the MMA in 2004 that people support the idea of negotiation. It sounds so simple. In fact, as we know from this and previous efforts, it's really complicated, which is the perfect lead in for Mark to talk about PBM transparency. Another place that feels like it should be straightforward and yet is, I think one of the issues that makes it hardest to tackle some of the changes that people would be interested in seeing in the system. So Mark, can you walk us through PBM transparency and
where
key points are?
Sure. And I also think it's important that you had mentioned that the folks who are listening to this will have interest in both Medicare and the commercial sector. And Tricia made the point that the inflation rebate as drafted in the current legislation does apply to both. And I just want to hit that again, because then you are right that this one also applies across all markets. And here, the fundamental point is that a PBM, and I'm also going to modify this in just a second, but a PBM can't enter into a contractual relationship that prevents them from sharing information with their client or in this generally the plan, so that the plan has full information. Now, there's a very long list of, a contract with a drug manufacturer, distributor, wholesaler, rebate aggregator, but fundamentally, it's if you are involved in the chain delivery chain, you can't sign agreements that prevent you from sharing information. There's also a long list of the information that needs to be reported as part of this in terms of fills and spending and acquisition costs and that type. There's a whole list of information that is to be required. The other little modifying point, which I flagged a second ago, is that if you're a health plan and you're involved as any part of the kind of middle, delivery system, either as owning a PBM or somehow involved with some other actor, you are also required to not sign agreements that prevent you from sharing information. So it's directed to the PBMs, but consolidation has been occurring all over this market, and to the extent that there's a consolidated position, you're also held to the same standard. I think, of course, I've completely forgotten your question, but I think that was at least part of your question. Hopefully it came in a bit on point.
You got it right.
Why don't I pause?
I just wanted to flag that the PBM transparency issues are huge, and that this, by having the reporting every 6 months and prohibiting gag clauses, well, that's my interpretation in the contracts, that would be really important on the commercial side as well. I'll give you a quick vignette, and then I'm mindful of time, we should move on. When I worked for a large pharma and bio firm briefly as their head of global policy, we were looking at pricing issues, and I turned around to our HR department and said, I'd like to see our contract with the PBM serving our employees. I want to see our rebates. I want to see the delta between list and net, our money flows, what's going on here. And many months into that exercise, I still couldn't get that information. My sense was our HR people didn't even necessarily have the information. And so it's one of these sort of eye-opening, if not gobsmacking artifacts that I think is not unusual in the industry itself. So I really think
it's absolutely true. I've known people who've had to sue to get the information about themselves, and it's
about their own contract.
Yeah, it's insane.
Yeah, that's right. And so it goes back to what I was saying at the beginning, that people argue the list prices aren't important. Well, we know that they're phenomenally important to uninsured and underinsured people, and there's often lack of clarity between the list and net.
Well, and I mean, the list prices are, and I think Tricia might have already said this, because again, she says all the good stuff, but I mean, they're very important to the Medicare beneficiary at the counter as well. And that's 60 million people. So
proportionately high users.
It is. And I think, list price and net price are both important factors, and anybody who dismisses either side of that equation, I think is kind of missing the ball. And then one other thing I'm going to say it here, just given time and all of that. I have enough economics of, like, I understand the notion of kind of coming to agreements and not having the agreements be public, sort of price discrimination, and that you can get the best agreements if that's the case. But I think the shenanigans in this sector have become so extreme that I think we're kind of past the utility of that thought, and bringing stuff above the waterline is the direction that we have to go. But you didn't ask that, so I'll stop.
I'm glad you contributed it. I think it's an important point, right? And this is what I've said about this market for a long time, that the normal rules of economics and rationality really don't apply here. We've got so many competing and perverse incentives. So I think one thing we should talk about, I'm mindful of time. I felt like we had all the time in the world, and now we're steaming toward and want to be able to get to some of these questions. So BBB is on hold. There's lots of discussion about what I'm calling the baby BBBs, or BBB offspring, what pieces could be shorn off and moved along. When, with both of you having looked at these provisions in various incarnations for many years, and knowing the political environment we're in, is anybody willing to hazard a guess? Do we want to think about, if they did smaller versions, would some of these provisions, maybe the inflation rebate, since it had been bipartisan before, are there some of these pieces that could still make it over the finish line in a legislative vehicle?
I could start, and Mark, I'm sure will have greater wisdom to impart. I'll start with the out-of-pocket cap, because that is something that really has been very bipartisan, and actually it's supported by the pharmaceutical industry. So I could see that being a proposal that could move forward. It's not clear it would do much about drug pricing, which is the larger issue that we're talking about, but it certainly would do something to help people on Medicare who have high drug expenses, and there are about 1 million people who exceed the catastrophic cap. So I think because of bipartisan interest in pharmaceutical industry support, that could be on the table. I think the inflation rebate could also be on the table. It is something Senator Grassley and Senator Wyden put forward. There may be controversy about applying it to private payers and employers. The insulin cap is very popular. You know, in the past, there has been some hesitation to legislate changes disease by disease. And I think there are pros and cons in doing that. But this has been particularly popular. There are members of Congress who have been very vocal about the cost of insulin in particular. So I could see this holding firm. And then I think I'm going to defer to Mark on negotiations. I mean, I think in some ways some people would consider it the heart and soul of the package, but it also may be the most controversial.
I don't think there's any question it's the most controversial. And I think you are correct that the Part D reform, that, you know, the catastrophic cap, the $2,000 or whatever number it was, I think the Senate bill might have had 3,000, I can't remember, is something that is both bipartisan and, if you design it right, in a sense, pays for itself. The savings are poured back into the benefit, and you can make it all just kind of level out. The inflation rebate also had, bipartisan support, as you pointed out. And then the negotiations where, everybody parted company. But I would come at the answer just a little bit differently. The first thing I would say is, in an odd way, and this is we're in a talk and it's a generalization. In an odd way, the fight around the BBB has moved away from drugs. Like, there was an intense, attention to it, Tricia has already pointed out, and it was very much watered down. But people basically were like, okay, we're done. And it was really other things in the BBB, that are, kind of getting in the way. So one strategy, there's still a reconciliation path out there. One strategy is whatever the elements are of the BBB that can come to agreement of which drugs could be part of that, you could see something move that way. And there are certainly people talking about a path like that. Now, if that train leaves the tracks, and there's lots of scenarios under which that's the case, then I associate myself with Tricia's remarks that the stuff that could show up in a one-off way in some other piece of legislation would be the two items, the Part D and the inflation rebate. Maybe the insulin cap. It would have to be paid for, but it's not gigantic, and so I think that could potentially happen. And the negotiation would be the stuff that wouldn't survive that, in my opinion.
So there's what might survive in the legislative form. I think then the other question, if past is prologue and we become unable to do that, is if no legislation gets across this year, what could or should the administration do using Innovation Center authority or anything else that might be at their disposal? Do you all have any thoughts or ideas? Or
I think there are a number of steps the administration could take to move the train forward using demonstration authority. It could, for example, begin to test models where there's more of an effort to link price with value in some fashion. There's an idea that has been floated of setting a price initially and then increasing that price if over time it is demonstrated that a certain drug improves outcomes, rather than kind of do the reverse and set a price higher and then pay for many years and find that it may or may not have improved outcomes. So maybe there's some work that could be done there. There is certainly a fair amount of interest in limiting out-of-pocket spending, and in doing that, perhaps there could be some better research on the effects of that on utilization and outcomes as well, and savings, which is something that CMMI has to take a look at. more work could be done on Part B drugs. I know that was tried and kind of smacked down when the Obama administration tried it. But certainly this is an area that is very problematic for people on Medicare who are taking very expensive cancer drugs, for example. And it's expensive for them, whether they're in traditional Medicare or in Medicare Advantage. They still have the same coinsurance. And if they have an out-of-pocket cap, it's relatively high. So I think there are a number of ways that CMMI and the administration could move forward if they choose to do so.
Yeah.
Or areas that you would point CMMI to and say, well, maybe this is a place that would bear fruit if you've got one or two bites at the apple?
Yeah, I mean, decidedly, I think the Part B it is an opportunity. And I think there's the clarity of their ability to go in and try alternative models under their demonstration CMMI type of authority are there. And I think, they could try hybrid percentages and fixed add-ons. They could take, there's a number of things that they could try there. Anything that's done by the administration is likely to be challenged in the courts. And so I think that's in putting this together, trying to think about the areas, and this is why I first think of Part B, where your authority is probably the clearest and the way you could design the demonstration would withstand challenges. If I were in their shoes, I would start in B. Now, that does not mean you can't move it into D, but I think it's more tricky because of the non-interference clause.
I think that's really helpful. I'm going to just ask you guys a couple more things, and then we're going to shift to the audience Q&A because a lot of interesting questions are coming in. And one leads to the next. Adelhelm, right? And I know Tricia's done a bunch of work on this. This has obviously generated really emotional charges and assertions from some corners, and people are worried about what it means for innovation. So, Tricia, can you help us quickly separate sort of rhetoric from reality and talk a bit about the CMS CED proposal, and just briefly, and implications for Medicare and spill over to employers, even though people think of this because it's Alzheimer's as primarily a Medicare population, there are with early onset, and that this is primarily indicated for early disease, implications for employer plans as well, probably in their supplemental form, but also the ancillary services and for people who aren't yet Medicare eligible. So if you could just give us a brief moment about why it was, why CMS might have gone with the CED approach.
Let me just back up a little bit, just in case this is a little bit too technical. If this weren't so real and the stakes weren't so high, this would just be a fascinating case study, because it's almost the example of the drug that everybody has been worried about. Like, oh my gosh, a new effective drug comes to market at a very high price. What's the country going to do? And if it's for cancer or for Alzheimer's, what will we do? And hey, Medicare has no authority to do anything. So that's kind of the scary story that people have been talking about, and why people have said we need to give the government more tools to do something about a high-priced drug. Adrecatmap came along for Alzheimer's disease, and it got accelerated approval from FDA, which is very controversial at the time because there was disagreement about whether or not it was effective, but it did get accelerated approval, which suddenly put the spotlight on CMS because CMS had to make a decision about Medicare. It is a bigger deal for Medicare than it might be for employers, but it's not exclusively a Medicare issue. Medicare has more people with mild cognitive impairment, but employers are also, particularly employers with older workers or retirees, are on the hook for their older workers who themselves or their spouses have some form of cognitive disease and would potentially take this drug. So a lot of interest in what Medicare was going to be doing for this drug. And while Medicare was working on its national coverage determination, some of the health systems out there, like Cleveland Clinic, Mount Sinai, Mass General, Brigham, they're all like, nope, we're not going to do this. We're not covering this. We don't see the evidence. Same with the VA. But Medicare was working on a national coverage determination, and Medicare came out with a coverage determination that said, and this is still in proposed form, but we are only going to cover this drug if it is provided as part of a clinical trial. And that was the coverage with evidence determination, because there was reason to question, given the evidence at hand, whether the drug would impact patient outcomes. So that's kind of where we are. And it is a new place to be for Medicare, because I don't believe Medicare has ever done this particular thing before for an FDA approved drug for a condition for which it was approved. So we'll wait and see what happens when this determination is finalized, which I think will be in April. You know, it does have sort of big implications for what it means to bring a drug like this to market. And particularly, you know, remember, this came to market with the $56,000 price tag. Biogen did cut it in half in December, but it was still a whopping amount of money. When we did our analysis, we were thinking, even if just 500,000 people take it, which in Medicare is a rounding error, that could be $27 billion in a year. You know, that's real money that affects Medicare spending. And it also, as we've seen this year, also really had an impact on premiums at a lower price and with fewer people using it.
Well, and again, the sort of wand waving from the manufacturer side of this is our price. No, this is our price. You know, also just indicates, again, I think some of the irrationality in the system and where we are. That brings us to one final question for Mark before we take the audience questions, but on this notion of evidence and value and how are we evaluating, getting that impartial information. I know Arnold has helped fund ICER through the years. You know, Congress created PCORI back during the ACA and the Recovery Act. And there's just, I think, a desperate need for physicians and patients to get independent information. You know, it can also be used by payers and others, but really the point a lot of these efforts are trying to do is to get that kind of independent value-based information to help guide clinical decisions that are made by patients and their physicians. So can you give us a little sense of what you think ICER, the role that ICER can play these days, and whether other organizations should be wading in here, and, you know, how are we looking at valuing new products or new formulations?
Yeah, I can do that. I do want to add on one other comment to the Alzheimer's conversation. And I think a few things. There is this whole issue, and this does kind of play into the ICER question of kind of cost effectiveness and understanding. There's this question of, you know, is this drug different enough relative to other things, or a new class that would essentially drive the price. But in this particular case, the Alzheimer's, even if you pull the money out of the equation, the thing that I found disturbing about it, beyond the notion of like highly disputed surrogate endpoints, highly disputed evidence, is there were people who were hurt by this. And so I think the other, you know, meaning the brain swelling, that type of thing, and it was not insignificant. And I think the other thing that I would say for CMS is, you know, a lot of people are saying, well, this is really just about the money. And I'm sure that that matters. And I subscribe to your comments about it's 56, now it's 23. It's like, what is this price tethered to? But there is actual harm involved here that I don't think in the current debate is getting enough attention. And I'm not sure I would have wanted to be an administrator that said, yeah, everybody gets it. And so I think there are many reasons that kind of drove them into this particular lane. Sorry. But then
you're right. And it's trial diversity, it's getting more data. Like
there's that.
A lot of reason to move. Yeah. To ask for more data before it's more broadly available.
Yeah, and for the drug to be provided under more careful, controlled circumstances.
Yeah, and I think that they were put in a very difficult situation. And I also would point out the industry is not in any way encumbered with continuing its own clinical trials to prove whatever product, you know, or alternative, because there are competitors for this product, has an effect. And if they have an effect, then it should be approved, and, you know, Medicare will have to figure out how to cover it. But anyway, you didn't ask that. I'm sorry. ICER. So, I think in a very, and again, out of time, and you can only go down so deep. There's only a few ways you can think about pricing. You can think about reference, like, is this drug like another drug, and is it better or worse? And assuming that price was reasonably set. You can think about cost, but that information is not available in a general way to really begin to think about, I'm going to price a cost. And the other way is to think about it as value. And that's what ICER is trying to do, is say, at this price, does the value of the drug bear out? There has been some, this is not particularly embraced by the industry, although I would point out there are some companies who have embraced ICER's analysis and used it to guide some of their pricing, but by and large, it has been rejected. And there are, of course, concerns on, like how the methodology and valuation of life and all, reasonable conversations. But the notion of what you can tie to for the purposes of pricing is pretty limited if you don't have cost. It's one of the ways is to try and sort out the value, the price of the drug relative to the value of the drug that it provides clinically to the patient. I guess a longer run concern I have, and I think all three of us have talked about this at some point in time, is the notion that even from an affordability point of view for, the employer, for the family, or the taxpayer, you can have drugs that have value, but they are still unaffordable. And the direction of the pipeline is going in the direction of, specialty drugs, gene therapies, and that type of thing. And the notion of, even if they have value, how much they can be afforded, I think is still going to be a question that even if you clear the value hurdle, it doesn't mean that it's still affordable. And that is going to be a deep philosophical question we're going to have to face. We'll stop there.
That's great. Okay, well, we're trying to get to a couple of the audience questions. One is a question from Patrick. It says, there's so much focus on insulin, but in reality, more people with diabetes take injectables and oral agents whose cost per month is often higher than insulin. Why isn't this a driving force? And I'm going to hazard a first answer at it, but welcome either of you to jump in as well. I think insulin is so easily and readily understood and became the poster child. There were some notable deaths, over the last decade of people with diabetes who were unable to afford insulin, and sort of their families talked about that as being the driving factor in their death. And I think it's well understood. And in the early part of the dramatic price increases of the last 15 years, insulin products were driving a lot of that. I think that many of them have slowed down over time, although you saw at the start of the webinar that 7 of the top 22 were still diabetes specific products, some of them insulin, some of the other agents. But I think that the policymakers, I'd hazard a guess, just felt like it was really important to have something that is clearly for the diabetes population, especially when you look at the trends that we have, the ever increasing unsustainable trends in disease burden for that condition. I do think, though, that some of the other therapies that they take would get captured, though, in some of, in the inflation rebates and in the negotiation pieces. So that would be my answer on that. But I don't know if Mark or Tricia have something else.
I think diabetes is fairly common. It's unfortunately too common. And I think members of Congress, like the rest of us, know people with diabetes. So it is not uncommon to hear stories about people who have struggled with the cost of their insulin. They're more likely to encounter people to tell these stories. And I think the other injectables are used not as frequently by as many, and not by as many people. They're less top of mind. That's not to say their story is not compelling. It just might not be a story that everybody knows.
So we have another question from Mark, that his question is really getting to, could we do a DOD-based system, Champus Maximum Allowable Charge, a MAC, for Medicare and Medicaid, and eventually the commercial market? The CMAC prices are set by DoD because of their market size, prices based on the zip code where the drug is purchased. This person remembers meetings where a drug was thought to be too expensive and they got it reduced. But, I think DoD, and I'm no expert in DoD health policy. Tricia, I'm not sure how much time you've spent on it. Mark, you seem to be everywhere. So maybe you have a little bit more insight into the DoD health system. But I think it's a little bit like where the VA has a formulary and the federal supply schedule. It gives them a lot more power to get prices where they need to be and ensure access. The DoD system, I suspect, is somewhere between that and regular commercial market, because they do have commercial plans operating for them, but under certain constructs. So is there an opportunity to take a DoD-like system and look at that here?
Operationally, can this be done? Sure. Politically, can this be done? That's a different question.
And to that point, Tricia always gets to say all the good stuff first. But to that, right now, and I wrote the question. You said it was from Mark, so I was
true.
Right. No, I absolutely, Tricia is completely right, and you are already into it. I mean, there are differences here where if you have the formulary or the threat of a formulary, that is a very different negotiating power. That's very true in the commercial sector. And when people on the Hill started off on this road and thought about negotiation, explicitly it was they are not going to use a formulary. Anything approved would be covered. And when you do that, you have to take some of these other routes, which we could get into, but we're under a time limit here, of how you go at the negotiation and why it ends up looking different than DoD. The other thing I would say is DoD has a certain market power, VA has a certain market power, but it's not like Medicare's market power. And that goes back to Tricia's point, which is why it's so much more politically difficult to do it there, because if you do it there, you're really doing it and you have broad reach. I'm sorry, that was probably too.
No. And I think you raise a good point. The other thing too is, DoD is offering benefits as an employer, right? Totally different than the dynamic that Medicare has, which is all taxpayers are contributing when they're working and they are benefiting when they reach age of eligibility or satisfy disability criteria. And it also sets up just a different dynamic, and also the sheer number of bodies, right? So as we know in other payment areas, as goes Medicare, so goes the rest of the system. That's not been the case in drugs, where Medicare is going to be a follower on the rest of the system potentially, or charting its own path, but gingerly. So we have time for one other quick question. I'm mindful, maybe actually these are all complicated, and given that we're at 2:57, I wonder if there's any closing thoughts you guys have that you could wrap up with, because I think if we tackle a fresh issue, we'll run past time. Any takeaways? No.
I'll just say, you asked before for us to look in our futuristic ball and try to guess where the BBB is going, or baby BBB. And I'm loath to predict the future, but I will say, if nothing happens this year, I don't see this issue going away for reasons we've talked about. Affordability issues are very real. Also, the need for drugs that cure cancer. Today was a big day for the moonshot, right? The cancer moonshot announcement. People really do want to see progress and innovation, but they also want to be able to afford their drugs when they go to the pharmacy. It's not just a people issue, it's employers, it's unions, it's public and private payers. So I can't predict whether or not anything will happen this year, but I do believe that even if something does happen this year, I think there will be ongoing pressure to tackle this issue in the future.
And I would agree with Tricia. And the other reason, in addition to all the ones that she said, is at some point in time, Congress is going to want to do something. They're going to need money to pay for it. And, there's a lot of now drug policy out there where savings can be achieved without harming people. And so I think these kinds of conversations will be in play. And as noted, at least a couple of the ideas, the inflation rebate in particular, at least had bipartisan support at some point.
Yeah, I think that's right. Thank you both for spending time with us today. I hope it's been interesting for our viewers. We were up to about 400, I think, or even higher at the start. So people were interested in what we had to say here, and hopefully we'll be able to have more conversations in the future and keep doing what you're doing out there. We really appreciate you spending time with Virta and our customers, clients, and other people who are interested in what we're talking about.
Thank you for having us.
Thank you.